I want you to picture something for a second. And if you're listening to this on a run, or maybe while you're stretching, this might actually hit a little too close to home. Imagine your whole identity is tied to your ability to move. You aren't just walking to get from A to B. You're playing tennis, you're hiking steep trails, maybe you do CrossFit. Your body is the machine that lets you be you.
It's the athleisure mindset, really.
Okay.
Movement isn't a chore. It's, it's a language.
Exactly. Now imagine a joint injury taking that away. But here's the specific nightmare I want to drill into. It's not just the pain, it's the fear that even if you get surgery, even if they fix it, you won't feel like yourself anymore.
Right.
You'll feel mechanical, like there's a hinge inside you that just doesn't quite belong.
And that is a profound, legitimate fear. And historically, you wouldn't be wrong to feel that way. I mean, for decades, joint replacement was purely about pain relief. It was surgery for the elderly who just wanted to walk to the mailbox.
Not for performance.
Absolutely not. It was not designed for high-performance restoration.
Well, today we are flipping that narrative. We are going deep into modern hip surgery. And I don't mean modern as in, we use a sharper scalpel. I mean a fundamental shift in the philosophy of engineering the human body.
It's a total shift.
We're looking at how we moved from just fixing a break to preserving the machine.
We're talking about high-performance restoration.
To guide us through this, we have a really fascinating primary source. We've broken down an in-depth conversation with Dr. Coleman Fowble. He's an orthopedic surgeon at Midlands Orthopedics and Neurosurgery in Columbia, South Carolina.
And Dr. Fowle's an interesting character because his background isn't what you'd expect. He isn't your standard sports med guy. He's in orthopedic traumatology.
Which sounds intense. That's like car wrecks and industrial accidents, right?
It is. It's chaos medicine, basically. And we'll get into why that matters later. But it just changes how he sees the anatomy. He gives him a different toolkit for what we're talking about today.
Which is
the massive difference between replacing a hip and resurfacing it.
Yeah.
Why the angle of entry front versus back might save your athletic career, and this concept of bone banking.
Okay, so let's get right into the mechanics. Because I think for most people, myself included, hip surgery brings up one specific image: a saw, a hammer, and a titanium ball.
Right, the brute force approach.
Yeah, but Dr. Fowble makes this huge distinction between total hip replacement and hip resurfacing.
And most people just assume they're two words for the same thing. They're not. They are not at all.
Is it just a size difference?
It's a geometry difference.
Yeah.
A massive one. Let's start with the standard total hip replacement. This is the gold standard procedure that has been done for 50 years.
Okay.
In this scenario, to fix the arthritic joint, the surgeon has to remove the femoral neck and head.
Okay, pause. Remove the femoral neck. I'm trying to visualize that. That's the top part of the thigh bone that actually goes into the socket.
Yes. And it's not just the ball. It's the neck leading up to it. In a standard replacement, you are losing about 3 inches of your own natural bone.
3 inches? That seems like a lot. That's basically an amputation of the top of the femur.
It is effectively an internal amputation. They cut that bone off, they hollow out the femur, and then they jam a metal stem down into the marrow to hold the new ball.
Yikes. Okay. That paints a very vivid picture. So how is resurfacing different?
Dr. Fowble describes it exactly as it sounds. You aren't amputating the joint, you are capping it.
Capping it.
Think of it like a tooth crown. You grind down the surface of the damaged bone and you place a metal cap over the femoral head and a metal liner in the socket.
So you don't cut the head off?
No, you keep the head. You keep the neck.
Okay, so what's the bone loss there?
About 6 millimeters.
Whoa. Okay, wait. So we are comparing 3 inches of structural bone loss to 6 millimeters of surface shaving.
It's night and day.
That is. It's entirely different architecture.
Exactly.
But I have to play devil's advocate here. If I'm the patient and my hip hurts because it's grinding bone on bone, if the metal works, why do I care if I lose the bone? If the pain is gone, does it really matter if I have a metal stem or a metal cap?
That is the million-dollar question. And for a sedentary person, maybe it doesn't matter as much. But for the athlete, it matters immensely. And the reason is biomechanics.
Okay.
The offset of the hip, the length of the leg, these things aren't recreated by the surgeon. They're preserved because the original factory parts are still there.
Okay. That makes sense physically. The levers are still the same length.
But there is a deeper concept here that Dr. Fowble highlights. And this is the key aha moment for the active listener. It's a concept called proprioception.
proprioception, I've heard this term. It's usually described as body awareness, right?
It is, but let's go deeper.
Hmm.
Proprioception is your brain's ability to know where your limb is in space without looking at it.
Like closing your eyes and touching your nose.
Exactly that.
Mhm.
You can do it because of proprioceptors.
Yeah.
Now think about a high-level skier flying down a mogul field. Their legs are just pistoning up and down.
Right. They aren't looking at their feet.
No way. If you had to look at your 2 feet, you'd crash. They are feeling the pressure, the tension, the angle of the joint, and their brain is making micro-adjustments in milliseconds.
Okay.
Now, where does that signal come from? A huge amount of that feedback loop comes from the stress and tension in the bone itself, particularly the femoral neck.
The part they cut off in a replacement?
Precisely. If you do a total replacement, you sever that feedback loop. The brain sends a signal down to the leg, and the response it gets back it's muffled. It's like static on the line.
So it's like driving a car with numbness in your hands. You can turn the wheel, but you can't really feel the road.
That is a perfect analogy.
Wow.
Dr. Fowble is very clear on this. With resurfacing, because that natural bone and all the nerve endings around it are preserved, the brain recognizes the leg better. The feedback loop stays high definition.
So for the patient, that translates to what? Just feeling better?
It translates to confidence. It's the difference between thinking, okay, I need to move my left leg now, and just moving. It allows for a natural gait, better range of motion, and crucially strength.
You aren't fighting your own body's confusion.
You're not. I mean, if you're playing tennis, you don't want to be thinking about your hip. You want to be thinking about the ball.
Mm.
So resurfacing seems like the clear winner for the chassis, right? You keep the bone, you keep the feeling, but that's just what they do to the bone.
Mm.
The other piece of this puzzle, and maybe the more controversial piece, is how they get there.
The approach.
The angle of attack.
Right, and this is where we get into this debate of anterior versus posterior, front versus back. I feel like I see billboards for this now. Direct anterior approach. Is this just marketing, or does it actually matter?
Oh, it matters. It matters a lot. And to understand why we have to look at the anatomy, traditionally, hip surgery was done via the posterior approach.
Say for the buttock, which seems logical. There's a lot of padding there.
There is. But there's also the engine of your hip.
Mm.
To get to the joint from the back, you have to cut through the gluteus maximus fascia. And, more importantly, you have to slice through 3 specific tendons.
You have to cut them. You can't just move them out of the way.
In the posterior approach, you have to detach them to open the door to the joint. Now, they do repair them at the end. They sew them back up. But Dr. Fowble points to MRI data that is really telling.
And what does it say?
Even when those tendons are repaired, the muscles attached to them tend to atrophy. The trauma of the surgery, the disruption, it affects them long term.
So you have a new hip, but the muscles that stabilize it are permanently weakened.
In many cases, yes. And practically, this leads to those infamous restrictions. If you have a posterior replacement, your surgeon will almost certainly tell you, do not flex your hip past 90 degrees for the first 6 weeks.
90 degrees? That's just sitting in a normal chair.
A low chair, yeah.
Yeah.
Or sitting on a toilet. Or tying your shoes. Imagine not being able to bend over to tie your shoe for a month and a half because you're terrified your hip will pop out of socket.
That sounds miserable and terrifying.
It is. Dislocation is a real risk because you've compromised that posterior wall of muscle.
So enter the anterior approach. Going in through the front, how is that different? Aren't there muscles in the front too?
There are, but the anatomy is different. Dr. Fowble explains that with the anterior approach, they use an intramuscular interval.
Okay, unpack that jargon for me.
Think of the muscles in your thigh, like heavy drapes hanging next to each other. In the posterior approach, you're cutting through the fabric. The anterior, you're finding the seam between 2 drapes, putting your hands in and just pushing them apart.
So you aren't cutting any muscle.
You aren't detaching muscle from bone. You are working between them.
That sounds infinitely better. Does the data back that up?
It does. Dr. Fowble mentions that MRIs taken 12 months post-op show the anterior musculature looks exactly the same as the non-surgical side.
No atrophy.
None. The engine is untouched.
Which has to mean the recovery is faster.
It's not just faster, it's freer.
Mm.
Dr. Fowble reports, anecdotal evidence of less pain, which makes sense. But the big takeaway is the lack of restrictions.
No 90-degree rule.
0. You can bend, you can squat, you can sit cross-legged. Obviously, they don't want you doing box jumps on day 2.
Of course.
But that's for the bone to heal.
From a movement perspective, you are cleared. That psychological freedom, just knowing you can't mess it up by bending over, That has to be worth a lot.
It's massive.
Okay, so let me do some math here. We have resurfacing, which saves the bone and the proprioception, and we have anterior, which saves the muscle and the recovery time. Naturally, the smart listener is thinking, I want both. Give me the anterior resurfacing.
And this is where we hit the wall of difficulty. This is the real cutting edge. Because the answer is yes, you can have both, but finding someone who can do it is incredibly hard.
Why? If both techniques are so good, why isn't every surgeon in the country doing this?
Because it is technically a nightmare to perform. Think about the geometry again. In a resurfacing, you're keeping the femoral head.
Right, it's in the way.
It's totally in the way. You have to work around it to prepare the socket, which is deep inside the pelvis. And you're trying to do all of this through a small incision in the front without cutting muscle while basically looking down a hole.
It's like trying to build a ship in a bottle.
While looking through the neck of the bottle.
Yeah.
It requires a very high level of expertise. I mean, Dr. Fowble has been doing anterior replacements for 10 years, but he only started doing anterior resurfacing about 18 months ago.
So even for a pro, the learning curve is that steep.
Extremely. And this brings us back to that traumatologist background we mentioned at the start. I think this is the secret sauce.
Yeah, connect those dots for me. How does fixing a shattered pelvis from a car wreck help you do a sleek elective surgery like this?
Think about the environment of trauma surgery. Acetabular fractures. These are high-energy injuries. Dashboards, falls from height. The pelvis is shattered. The anatomy is distorted. It's bleeding. It's chaos.
It's not a clean textbook diagram.
Not at all. To fix that, Dr. Fowble had to develop a three-dimensional knowledge of the pelvis that most surgeons simply don't need. He knows where every nerve and vessel is, even when things are a mess. He's used to fixing fractures from the front and the back.
So when he's navigating that ship-in-a-bottle moment in an anterior resurfacing, he's not stressed. He's been there before.
Exactly. He's comfortable in the deep end. He explicitly says his trauma background made the transition to the interior approach feel natural because he was already used to wrestling with the pelvis in 3D space.
That makes me feel a lot better. You want a pilot who has flown through hurricanes, even if it's a sunny day.
Precisely. But there is a catch.
There's always a catch.
We've painted this picture of anterior resurfacing as the holy grail. And for the right patient, it is. But Dr. Fowble was very blunt. This is not for everyone.
But gets rejected.
It comes down to the raw materials. He notes that this is primarily for very fit patients with high activity levels. But the absolute deal breaker is bone quality.
Osteoporosis.
Osteoporosis, or even just soft bone. Think about it. Resurfacing is putting a metal cap on your existing bone. If that underlying bone is like wet chalk, the cap is going to sink or loosen.
It'll fail.
It'll fail. It's like putting a heavy slate roof on a house with rotten rafters.
That is a perfect analogy.
So if the foundation is weak, you can't resurface. You have to replace. In those cases, the standard total hip with the stem down the femur is actually safer.
What about weight? Does BMI matter?
It does. It adds a lot of complexity to an already difficult surgery. High BMI just makes that ship-in-a-bottle approach almost impossible because of the depth of the tissue. So to qualify for this Ferrari of hip surgeries, you need to be in pretty good shape to begin with.
Which brings us to the logistics. Let's say I'm the ideal candidate. Good bones, I'm active, but I live in, I don't know, Ohio. Dr. Fowble is in South Carolina. How does that even work?
This was one of the most surprising parts of the research. You'd expect a logistical nightmare, right? But they streamlined it. Midlands Orthopedics operates out of an ASC and ambulatory surgery center.
Which is different from a hospital.
Very different. A hospital is where you go when you're sick. It's full of pneumonia, infections, emergencies. An ASC is a focus factory for fixing things. They've been doing total joints there since 2012. It's clean, it's fast, it's specialized, and for the out-of-towner, they have a whole digital workflow.
So you don't fly in just for a 15-minute chat?
No. You do forms online, upload electronic x-rays, have video calls. You basically just show up the day before surgery.
That's impressive.
You stay in a hotel for 24 to 48 hours post-op, and then you go home. They coordinate with your local physical therapist back in Ohio or wherever you are. They'll order x-rays locally. It's a decentralized recovery.
It really feels like the future of medicine. Specialized centers of excellence that you travel to, then recover at home.
It is, and it relies on the patient taking real ownership of their recovery.
Speaking of ownership, I want to circle back to something you hinted at earlier. We've talked about the surgery, the muscle, the approach, but you mentioned bone banking.
Yes. This is the thought I want our listeners to really chew on. Especially if you are 30, 40, maybe 50 years old, and your hips feel totally fine right now.
Lay it on me.
We spend a lot of time obsessing over our muscles. We want to run faster, lift heavier, we track our macros, but we rarely think about our skeleton until it breaks.
True, bones are just the coat hangers for the muscles.
But as we just learned, your eligibility for this life-altering surgery, anterior resurfacing, depends entirely on the quality of the bone you bring to the table. You can have the will of an Olympian, but if your femoral head is soft, Dr. Fowble has to cut it off.
Wow. So bone banking is literally building up bone density while you can.
Exactly. It's heavy resistance training, it's impact exercise, it's getting adequate vitamin D and calcium.
Yeah.
You're making deposits into a savings account that you might not need to withdraw from for 20 years.
But if you do need to make a withdrawal,
You want to have enough at the bank to afford the resurfacing option. You are training today not just for PR, but to keep your options open for surgical engineering decades down the line.
that is a powerful shift in perspective. You aren't just training for the beach, you're training for your future surgeon.
It's the ultimate long game.
We've covered a lot. The geometry of bone loss, the importance of the anterior approach, the sheer difficulty of combining them. It seems like Dr. Fowble is really doing something special down in Colombia.
He is. He's engineering a return to identity, not just a reduction in pain.
I love that. A return to identity. Well, Dr. Fowble, thank you for the incredible insights. And to our listeners, start banking that bone. Go lift something heavy. We'll see you on the next deep dive.